Dear friends, apart from acute viral coryza that we commonly encounter in our day-to-day practice as a pediatric resident or pediatricians, invariably we come across many cases of acute otitis media. When to think acute otitis media? Whenever any child who is having acute viral coryza brought with sudden onset incessant cry along with the tugging of ear, it should be considered as acute otitis media unless otherwise proved. Then majority of us are supposed to use otoscopy to look for bulging red tympanic membrane, but practically it is difficult because no child will allow us to do. But let us make it as a habit to find what is there in the tympanic membrane. Let us buy otoscope and proceed further. And what drug we need to give? Is it amoxicillin 50 mg per kg or 90 mg per kg? Is it amoxiclav directly? Is there any role of myringotomy? Is there any role of admission and IV ceftriaxone? Let's see one by one. But before that, let me try to find out what is there in your mind regarding this acute otitis media. Question number 1. Erythema alone can suggest acute otitis media. Try to think, try to say yes or no to your mind before proceeding to the discussion further. Most common cause is Streptococcus pneumoniae. First line antibiotics is amoxicillin 50 mg per kg per day. Why not high dose? Levofloxacin can be used. Myringotomy if high dose amoxiclav fails. Azithromycin and cefixime are good options. Try to say yes or no. Dear residents and my dear practitioners, try to say yes or no to these following questions. Then we will proceed again. Okay? Come on, let's do it now. When to diagnose acute otitis media? As I already told you, the most common predisposing factor for acute otitis media is acute viral coryza. 20% of acute viral coryza will be complicated by acute otitis media. To me, as a pediatrician, as I told you already, incessant cry in the presence of acute viral coryza, whether ear tugging is there or not, I will consider acute otitis media as the cause for that incessant cry and high grade fever. Okay. So apart from that, what are all the things that we need to know? For a older children, the child can say, I have severe ear pain. So otolgia can be there. But for an young children, in the presence of acute otitis media, incessant cry will not be there. So what will be there? A young child who cannot convey in terms of words will be extremely irritable with or without cry, but they will try to tuck their ear often. In the absence of acute viral coryza, in the absence of irritability, just tugging of ear cannot be called as acute otitis media. Please remember that, because most practitioners will come across my child is tugging their ears often. I repeat, in the presence of acute viral coryza, in the presence of otolgia, in the presence of incessant cry, then you can consider acute otitis media. Tugging alone, pulling the ear alone cannot be due to otitis media. What are all the signs? Majority of us are supposed to do otoscopy to find out whether the tympanic membrane is bulged or not, whether the tympanic membrane is red or not, is there any air fluid level beyond the tympanic membrane, and look for loss of cone reflex. And again, cone reflex. And again, what are all the things you can see? Look at the video, look at this. The one on the left side is a normal tympanic membrane with a beautiful cone of reflex that is seen. Whereas the one on the other side, one on the right side shows bulging tympanic membrane as well as red tympanic membrane. At times, By the time you see the tympanic membrane would have ruptured and you can see a small hole in the tympanic membrane, or else you can see a mucopurulent, not a rhinorrhea, mucopurulent otorrhea. Mucopurulent otorrhea. I repeat, erythema without bulging, AOM cannot be AOM or AOM. Okay? Because even with severe cry or Valsalva maneuver, you can have this red tympanic membrane. So this is not rhinorrhea, that is otorrhea. So what is the carry home message with respect to symptom? Tugging of ear along with irritability and high grade fever can be considered as AOM. Erythema alone cannot be. Erythema with bulging, absence of cone of this one, absence of cone of reflex, along with air fluid, with or without air fluid level, should be considered as acute otitis media. Remember, erythema alone cannot be. Right. So now you have diagnosed. What are all the organisms that you need to know? Three most common organisms, whether it is a sinusitis or acute otitis media, three most common organisms are: one is Streptococcus pneumoniae, second one is Moraxilla catarrhalis, third one is non-typable Haemophilus influenza. Remember, after incorporation of Haemophilus influenza vaccine type B and after incorporation of pneumococcal vaccines, literally the cases that are due to Streptococcus pneumoniae and Haemophilus influenza type B are drastically reduced. Majority of otitis media are mainly due to non-typable Haemophilus influenza. Remember, your pneumococci is sensitive to amoxicillin, but your non-typable Haemophilus influenza and Moraxilla catarrhalis produces beta-lactamase. So you need to add clavulanate because the underlying etiology at present is non-typable Haemophilus influenza in a well-vaccinated child. And with respect to other organisms such as Staphylococcus aureus and gram-negative bacilli, they are more common causes for acute otitis media in newborns and young infants that are getting hospitalized. Otherwise, in your normal outpatient practice, no need to think in terms of a gram-negative bacilli or a Staphylococcus aureus. For a young resident who is interested to get a gold medal, look at this. One more new organism have been identified that is associated with acute otitis media. That is called, what is that? Aloiococcus otitis. Okay. But for a pediatrician, for a practitioner, for a resident, the only thing you need to remember is three organisms: non-typable Haemophilus influenza and Moraxilla catarrhalis. Both of them requires clavulanic acid. Whereas, because they are ESBL producing organisms, whereas your Streptococcus pneumoniae is sensitive to amoxicillin. But throughout the world, since there is an increasing incidence of resistance to amoxicillin, high dose amoxicillin of 80 to 90 mg per kg per day is being practiced right now. Right? Then you will be asking, when amoxicillin, when amoxiclav, when low dose amoxicillin, when high dose amoxicillin? We will be discussing it right now. So, the drugs you know. So what are all the bugs you know right now? Three organisms. So what are all the drugs that work? Amoxicillin will work. For pneumococci, high dose amoxicillin of 80 to 90 mg per kg per day. To cover Haemophilus influenza and Moraxilla catarrhalis, instead of amoxicillin, you could give amoxicillin clavulanic acid. So what will be the ideal drug of choice? High dose amoxicillin 80 to 90 per mg per kg per day along with the clavulanate in the ratio of 14:1. Amoxicillin 14 and clavulanate 1. Amoxicillin of 14:1 ratio. Okay, but remember your Haemophilus otitis media produced by Haemophilus influenza and Moraxilla catarrhalis are usually self-resolving even without treatment when compared to otitis media that is caused by pneumococci. As a result of which, the guideline says that you can start amoxicillin 90 mg per kg per day. If there is no response, you can go for amoxiclav 90 mg per kg per day. Okay, right. So you need to remember amoxicillin 80 mg per kg per day or amoxicillin clavulanate 80 mg per kg per day. Apart from that, cephalosporins such as ceftinir, cefpodoxim, cefuroxim can be used. But when these drugs can be used? These drugs are usually costly and not palatable. As a result of which, the cephalosporins such as cefuroxim, cefpodoxim, ceftinir can be used only in cases where the child after giving amoxicillin or clavulanic acid develop type 2 rash, not urticaria or not anaphylaxis. Where do we use levofloxacin? Levofloxacin is used only when the child develops urticaria or anaphylaxis after getting a course of amoxicillin. But to my knowledge, those instances, that is urticaria anaphylaxis, is very unusual in a child in India to amoxicillin. So never ever think about levofloxacin in a country like India where you get more often a tuberculosis which requires levofloxacin in drug resistant treatment regimen. Please do mind this one. Please do not use levofloxacin for this simple acute otitis media. Remember, your cefixim does not work. Cefixim works only for Haemophilus influenza. It will not work for your pneumococci or Moraxilla catarrhalis. So please do not use cefixim. Second, your azithromycin and clarithromycin are showing variable resistance, facing variable resistance against these organisms. Clindamycin is a good drug for pneumococci and staph aureus, but clindamycin is not a good drug for Haemophilus influenza non-typable and Moraxilla catarrhalis. Cotrimoxazole, again pneumococci is invariably resistant to it. That's why we are not using macrolide in the treatment regimen of acute otitis media. Your azithromycin, erythromycin, clarithromycin, not even your clindamycin. Please do not use cefixim. Please do not use cotrimoxazole. The third generation cephalosporin accepted are cefuroxim, cefpodoxim, ceftinir. Cefpodoxim is not palatable, so you give ceftinir. I have not used these cephalosporins in my 15 years of practice in pediatrics. Amoxiclav is more enough to cover almost all the organisms that we had discussed so far. Then at times people used to say, why a mild autolgia which resolves on its own, whether it requires any treatment? Okay, as I told you already, some mild otitis media resolves on its own. But you need to have a certain strategy for antibiotic practice in case of acute otitis media. So you know the bug, you know the drug. Now what is the stratification of antibiotic treatment? 3 points you need to ask. One is age. Less than 6 months, 6 months to 2 years and more than 2 years. Okay. This is point number 1. Second one is severity. A high grade fever of more than 102.2 degree Fahrenheit or 39 degrees Celsius along with severe autolgia, child not able to sleep, not able to drink milk, everything, incessant cry, and autolgia lasting for more than 48 hours. All these things comes under severe. And whether that acute otitis media is unilateral or bilateral. Right now you know what is the drug, what is the bug, what is the basic thing that you need to have before starting an antibiotic. What is the purpose of this classification into age, laterality, severity? The answer is very simple. At times you can follow either antibiotic or watchful expectancy. Some autoalgia, some acute otitis media do resolve without antibiotic also. So when should I give antibiotic? When should I can wait and watch and proceed for antibiotic? Very simple. Antibiotics are particularly indicated if the child is less than 6 months, irrespective of laterality, whether it is unilateral or bilateral, irrespective of severity. Even mild cases should also receive. Less than 6 months, irrespective of laterality and irrespective of severity. All severe cases with a fever of more than 1 or 2.2, severe autoalgia, should receive antibiotic. By the time the child comes to you, they will show some mucopurulent aturia. In all these instances, there is no wait and watch policy. You need to start an antibiotic where you can have a watchful expectancy in two instances. 6 months to 2 years unilateral non-severe and more than 2 years bilateral non-severe. In these instances, you can do a watchful expectancy or antibiotic. What do I do in my clinical practice when it is mild, otherwise the child is playful? I used to give ibuprofen 10 mg per kg per dose thrice daily. If the child becomes playful and tolerates ibuprofen, then I will ask the mother not to start antibiotic. But I used to write antibiotic in prescription. I will tell them, if the child develops severe autoalgia, incessant cry, high-grade fever, and if autoalgia lasts for more than 48 hours, you start antibiotic. Okay, but 80% of children with mild otitis media, unilateral 6 months to 2 years and more than 2 years bilateral will not be requiring antibiotic. But remember, all severe cases, all children with less than 6 months and all children with otorrhea should receive an antibiotic. What is the guidelines that says? Step 1, step 2, step 3. Step 1, start amoxicillin. Okay. Amoxicillin 80 mg to 90 mg per kg per day. Why not amoxiclav? The answer is simple. The otitis media that is produced by Haemophilus influenza and Moraxella catarrhalis that requires clavulanate will resolve on its own, but not your pneumococci causing otitis media. So the guideline says that amoxicillin 80 to 90 mg per kg per day can be started and wait for 48 hours. If the child doesn't respond, it means that it could be due to Hib or Moraxella catarrhalis, so that amoxicillin can be changed to amoxicillin clavulanic acid in the ratio of 14:1. Okay, then if you ask me, doctor, can I directly go for amoxiclav 90 mg per kg per day? The answer is yes, you can go for, no fault in that. Next, step 3. If the child is not able to take feeds, young child who is vomiting everything, the child is having very high grade fever, then you can consider ceftriaxone 50 mg per kg per day, a single dose or 3 dose. Guidelines are there. Okay, right. Just a single dose of ceftriaxone or 3 days of 1 day or 3 days, 50 mg per kg per day. It covers all these organisms. Even after starting ceftriaxone, if the child fails to resolve, then you can proceed for myringotomy, tymphanocentesis. By doing a tymphanocentesis or myringotomy, you are letting the pressure out so that the pus comes out. Once the pus comes out, majority of them will stop crying and fever will be reduced and child starts eating. And also you can send the sample for culture and sensitivity to make a tailor-made management. But 99.99% cases will not be requiring this tymphanocentesis. Amoxiclav high dose 90 mg per kg per day. is more than enough in almost 90% of cases. I have not given ceftriaxone even to single case in my 15 years of practice. When amoxicillin and when amoxicillin clavulanic acid, when there is no intake of, when the child has not received antibiotic in the past 30 days, the child is not attending daycare, the child is not having associated conjunctivitis, because Haemophilus influenza, one particular strain, is notorious to produce both conjunctivitis and acute otitis media. You all know that the Haemophilus influenza is beta lactamase and I need to start amoxiclav. And finally, so these are all the two indications where you start amoxicillin alone. But remember, 90 mg per kg per day. The child had not received amoxicillin in the past 30 days. Second one is there is no associated conjunctivitis. Start amoxicillin. So when amoxicillin clavulanate, the child had received antibiotic in the past 30 days. The child is attending daycare where so many drug resistant bugs could be there. Third one is associated conjunctivitis. Fourth one is non-response to amoxicillin. In these cases, amoxicillin clavulanate can be started upfront. What antibiotic am I using? I am using amoxicillin clavulanic acid upfront at 90 mg per kg per day in my clinic. Okay. Duration of symptoms. Less than 2 years, invariably you need to use a total duration of 10 days of antibiotic. For 2 to 5 years, 7 days. For more than 6 years, even 5 to 7 days of antibiotic is enough. It doesn't mean that 10 days, but what do I follow? 10 days for all. But less than 2 years, 10 days. 2 to 5 years, 7 days. More than 5 years, 5 days is enough. If the child develops urticaria or anaphylaxis, the course can be completed with levofloxacin. Less than 5 years, 20 mg per kg per day in 2 divided doses. More than 5 years, 10 mg per kg per day in 2 divided doses. But I have literally not seen any case of hypersensitivity, urticaria or anaphylaxis to amoxicillin. The child would develop, some child had developed minimal rash. But for those rashes, cefuroxime, cefdinir and cefpodoxime is enough to complete the course of antibiotic. Cefpodoxime 10 mg per kg per day in 2 divided doses. Cefdinir 15 mg per kg per day in 2 divided doses. At times once daily dose can also be followed. Remember, acute otitis is more prone to produce notorious complication because of its proximity to the cranium. When a child with acute otitis media develops fever, headache, altered sensorium, you need to think in terms of subdural empyema, brain abscess, okay, extradural empyema, meningitis, etc. When a child with acute otitis media is brought with the 6th nerve palsy and pain in the distribution of 5th cranial nerve, trigeminal nerve, this is, you all know, Gradinego syndrome. On examination, when you find a destructive pearl tumor from tympanic membrane, it is nothing but cholesteatoma. Diplopia, when the same child is with AOM, brought with diplopia, headache, papilledema, blurred vision, you all know that it is nothing but signs of raised ICT. In the presence of acute otitis media, when you have these symptoms of raised ICT, it is called otitic hydrocephalus. And at times, after giving antibiotic, when you see tympanic membrane, it becomes opaque and immobile. It is nothing but otitis media with effusion, OME. At times, they are associated with deafness, conductive deafness. So, you need to screen the child whenever you find this tympanic membrane. Even then, better all children who resolve from acute otitis media should undergo a otoscopic evaluation to look for this opaque tympanic membrane and to find out the associated conducting hearing loss. When the same child starts developing vomiting, tinnitus, nystagmus, it is nothing due to labyrinthitis, extension of infection into labyrinths. Alright? So with this, now you say yes or no right now. Erythema of tympanic membrane alone can suggest AOM? No. Erythema along with irritability, high-grade fever, incessant cry, bulging, air fluid level. Any one of these should be present. Most common cause is pneumococci. It is literally replaced by non-typable Haemophilus influenza in children who have received vaccination. First line of antibiotics is not amoxicillin. First line is amoxicillin, but 80 to 90 mg per kg per day as per guidelines. Levofloxacin in children with type 1 hypersensitivity following amoxicillin, the answer is yes. Myringotomy if high dose amoxiclav fails, no. Step 1 amoxicillin 80 mg per kg per day. Step 2 amoxicillin clavulanate 80 mg per kg per day. Step 3 ceftriaxone 50 mg per kg per day. When ceftriaxone fails, myringotomy or tympanocentesis. In this case, it is not myringotomy, it is ceftriaxone. Azithromycin and cefixime are not good options. Azithromycin, cefixime, clindamycin, clarithromycin are all not good options for acute otitis media. Thanks a lot. Okay, bye-bye.